Hello and welcome to my Ophthalm teacher. In the part one of this video lecture, we talked about the evolution of cataract surgery and we discussed intracapsular cataract extraction, which is an obsolete technique now. So in today's class, we're going to read about the two most popular methods of extracapsular cataract extraction, that is small incision cataract surgery and phacoemulsification. I'll try to teach you both the techniques side by side so that it is easier for you to understand, and we'll also see a couple of videos. So just like any other surgery, there is part preparation before the cataract surgery, and that includes some pre-surgical investigations, the routine ones. Patient's vitals have to be checked, xylocaine sensitivity if you're going to give a peribulbar or a retrobulbar block, pupillary dilatation with tropicamide and plus minus flurbiprofen, which helps to sustain the pupillary dilatation. Overnight fasting if sedation is required, such as uncooperative patients and children. And of course, the most important part preparation with 5% povidone iodine. Now, these are the various types of neural blocks that are given in cataract surgery. So the first three, those are various positions of giving the peribulbar block. Now the peribulbar block is basically an injection of either of these three agents or a combination of these agents along the orbital wall and outside the muscle core. So it provides analgesia and akinesia, right? Then there is the retrobulbar block, which is given inside the muscle cone and at a certain incline. Okay, it also provides analgesia and akinesia. And there is a subtenon block, which is given below the tenon's capsule. So these are the different types of blocks that are given to provide analgesia and akinesia. With the advent of phacoemulsification, we have started using topical anesthesia, which consists of proparacaine drops, which are just instilled into the eye a few minutes before the surgery, and it provides you analgesia. Akinesia is not provided, so the patient has to be cooperative. If one is giving a peribulbar or a retrobulbar block, one needs to do digital massage on closed eyelids so as to reduce the orbital pressure. Else, the orbital pressure is going to increase, the vitreous pressure is going to increase, there is going to be a lot of back pressure, and it's going to cause complications in surgery. So always we massage after doing a retrobulbar or a peribulbar block. If required, an osmotic agent can also be given. Now, the instruments used for ECCE differ according to the techniques. So, depending on the step, various instruments are used. The first step is opening the anterior capsule. The second step is dissection, removal of the nucleus, then removal of the lens cortex. This is an optional step. And the last thing is IOL implantation. So wound construction, in the last class, we saw how wound was constructed in ICC and how the wound construction evolved to phacoemulsification, where tiny wound of 2.8 to 2.2 to 2.8 mm is used. So that's the size of the wound and the location of the wound. Now, remember that in small incision cataract surgery, a sclerocorneal tunnel is made. So it's not a monoplanar incision, unlike in ECC and phaco. This is by ECC here, I mean conventional ECC. So this is a tunnel, okay? It is a triplanar tunnel, which is self-sealing in nature. That is the classical feature of SICS. So these are some blades used to make these incisions. The blunt ones are known as the crescent, and the pointed ones, which are diamond shaped, are known as keratin. And also there are side blades, which are angled blades. So the first step is, after entering the anterior chamber, is making the opening in the anterior capsule. Now, it's a very thin structure and something pointed, but also very, minute has to be used to make an opening. So what we do is we make a cystitome. A cystitome is basically the bent tip of a 26 gauge needle. It is used to puncture the anterior capsule, and the tip itself is used to make a circular opening. Sometimes, instead of this cystitome, specialized forceps known as utrata forceps are used. So for example, this is the cystetoe and this one is the utrator forceps. So this forceps has a little tooth at the end. It grasps the capsule and it peels it. So this is known as a continuous curvilinear capsulorhexis, whereas this is known as cannular capsulotomy. The next step, once the opening is made, is to deliver the nucleus out of the capsular bag. That can be manual or using phacoemulsification. So the first two methods are manual methods using the given instruments. And the ultrasonic fragmentation is, of course, phacoemulsification. Again, this is a wire vectis. This is the lens hook. And this is the Aruga's forceps, not used anymore. So most commonly, a vectis is used to deliver the nucleus when delivering it manually. And this, you see, this is the phaco probe with this is the tip which vibrates, okay, and provides that ultrasonic energy used to break the nucleus. And this is the sleeve used for around which water flows out. There is continuous irrigation and it helps to cool. Once the nucleus has been removed, the peripheral cortex remains, which is soft and fluffy and can simply be aspirated. So there is irrigation and there is aspiration. Two things are happening simultaneously. Again, it can be done manually with the help of a Simcoe cannula, or it can be done by a pump system. So this is the Simcoe cannula used in conventional ECCE and SICS. And below are the irrigation and aspiration probes. It can be bimanual or it can be coaxial. That is, both irrigation and aspiration ports are in the same probe. So a little bit about SICS. It's manual small incision cataract surgery. It's a low-cost surgery, small incision form of ECCE. Unlike traditional ECCE, it is a self-sealing sutureless wound. It is triplanar in nature, and SICS is still being done in a number of resource-poor settings because it is cost-effective and simpler. At the end of 6 months, the visual outcomes between SICS and phaco are comparable. So this is that sclerocorneal tunnel of SICS. You see, it's a triplanar tunnel. It is constructed that way so that there is a self-sealing effect. Nothing can leak out of the tunnel like this, okay? Post-surgery. Now, that is the incision on the sclera. Next, the crescent is being used to make the sclerocorneal tunnel with side pockets. The next step, a continuous curvilinear capsulorhexis is done with the help of a cystetoe, which is a bent 26 gauge needle. That's a beautiful CCC over there, about 5 mm in diameter. The wound is enlarged because the IOL has to be inserted and the nucleus has to be delivered manually. The side ports were enlarged. Another side port is made for any manipulation with the help of a second instrument if needed. Next, the nucleus is separated from the cortex by a process known as hydrodissection, in which water is injected below the anterior capsule. So you see the nucleus has separated out into the AC and it is delivered with the help of a wire vectis. What remains is the cortex that can be easily removed with the help of a Simcoe cannula that I showed you. See, it is fluffy and soft and easily removed. Next, the chamber, anterior chamber, is going to be reformed with viscoelastic, and a non-foldable 1-piece IOL is inserted and dialed into position. That is the capsular bag. So that is the end of the surgery. That's how it looks. Now coming on to phacoemulsification. I'll show you a video of this and you'll see how it differs. So this is an ECC technique in which the incision is much smaller and the nucleus, instead of being removed manually with the help of a vectis, is broken into several small pieces by the ultrasonic technique and delivered. Right? So this ultrasound machine uses something known as a piezoelectric crystal which vibrates at a given frequency, and the vibrational energy is transmitted into the nucleus and it breaks the nucleus. The second most important thing is there is irrigation as well as aspiration from the same probe. right? There is a continuous irrigation, that is water, which flows out of this phaco sleeve, and this metallic part helps in breaking the nucleus. And in the aspiration mode, it helps to aspirate the cortex or the viscoelastic substance, whatever. So the tiny 2.8 mm corneal incision with the help of a keratome, a side port incision for manipulation. Now here, just to make you understand, the capsule has been stained. So see, that's a CCC being done with the help of a uterata. Hydrodissection. Nucleus is separated from the cortex by injecting fluid under the anterior capsule. See, they're showing you the phaco tip, right? And that is the entire control system of phaco. See, hydrodissection is important anyway because you cannot just pull the lens, the cataractus lens out of the bag. You have to separate the cortex and the nucleus. Else, with phacoemulsification, there is a chance that the entire, bag might be pulled out. It's a very powerful machine. So you see, the nucleus has been divided into four parts, four small parts, and each of the four quadrants is removed easily by the machine. On the left side is a manipulator or a dialer, which helps to move the nucleus with one hand. That's the cortex being removed. The cortex, as you know, is very soft, and this is a coaxial system which is irrigating and aspirating at the same time. Visco is injected to fill the bag, enlarge it, and see in the intraocular lens. Now, this lens is a folded lens, as you can see, right? So, as it enters the eye, as it enters the capsular bag, it gets space and it opens up, just like that. So, that is the end of the surgery, a very well maintained anterior chamber. So the advantages are there are lesser wound-related complications, faster healing, better rehabilitation, and the AC is always maintained because there is a constant irrigation from the phacoprobe. The IOL implantation in SICS as well as phaco, both foldable or non-foldable. Of course, in phaco, you are only going to use a foldable IOL because that is the point of a small incision, right? So the foldable IOL in the folded form, it goes inside the eye and it opens up. A non-foldable IOL is usually inserted in SICS because it is being non-foldable, it requires a larger wound size. So for in the bag fixation, the IOL diameter is usually less than 12.5 and the optic diameter, that is the circular part, is about 5 mm. So we aim for a capsular excess of at least 5 mm or 5 to 5.5 mm. Wound suturing in SICS and phaco is not required. It is required in the conventional ECCE. Sometimes if there is a problem with the wound or some eventful surgery has happened, then wound suturing can be done. And what is the suture used? We used 10 IOL. So post-operative course, that's how the eye looks on POD1. You see that's the beautiful IOL that is shining. The cornea is absolutely clear. The iris, the pupil is round and the AC is quiet and the posterior capsule is intact. It is behind the lens. The implant is stable. It is not moving. There is a red reflex when you see on distant direct ophthalmoscopy and the intraocular pressure should be normal. Post-operative care consists of topical antibiotic and steroid combinations for 4 to 6 weeks, 3 visits, and at every visit you do a visual acuity and if required an intraocular pressure, and glasses are prescribed at 6 weeks. So the presentation is going to be uploaded on my YouTube handle and you can always revise. And in the next class, we're going to talk about the complications of cataract surgery. So thank you all for listening.